So I welcome all of you to the 52nd session of the Weekly Huddle. If we count one for each week, then 52nd would make it one complete year. And I don't have any formal clinical topic to discuss this time. I do have a topic to discuss, which is more related with education per se, rather than talking about any particular medical topic. So my idea of today's session is to keep it absolutely open so that anybody has got any thoughts to share about the model of education, how we teach, how we learn, particularly in regards to what we are trying to do through this weekly huddle for the last 1 year. That is something that I would like my attendees to share their thought and tell us how they think learning should be in the modern age or the new age, how the learning should be. We went from the chalk and blackboard model all the way now where even big CMEs are happening on a web platform. Nobody would have thought that something like this, where people are now recreating a big venue where virtually you have got 3 different halls where you can enter and whatnot. So it's certainly a different world that we are living in. And it's very pertinent for us to ask ourselves how we see the medical education is going to go forward. And by medical education, I don't necessarily mean the formal education like your MBBS or your MD, but more like continued medical education, things that we doctors do every single day to keep ourselves updated with the upcoming science and knowledge and experience and whatnot. So I think a lot of this needs to be discussed uh, in spoken words rather than just putting it hypothetically. And before I invite thoughts from my attendees, 2 things. One is I would like to take pictures of every attendee who is there today. So at some point, I will ask you guys to turn on your camera. I'll just take a snapshot on the screen, which I can share with you later on. So that way I will have something with me to, for me, like a treasure. And second thing is, I would take a few minutes to walk you through how we started with this weekly huddle and quickly go over the topics that we have discussed over time and ask for suggestions and whatnot over the days. And lastly, it was my intention that in a New Year session, I would like to do this huddle in person over dinner with people sitting and actually talking to each other in person. With the COVID scenario, that unfortunately didn't happen. So what my intention is that once things settle down, I would like to host an evening for all of my huddle attendees who can join us, and then we can have a nice chat amongst ourselves. So with that, let me just brief you about how it all started. This was in March, April of 2020, when the lockdown was announced, we were trying to recalibrate ourselves in terms of how the education should go, particularly the resident education. As you all know, Care Hospital, along with many other hospitals, we have a residency program. So we wanted to see how that thing is going to work. And very obvious thing that came out was webinars. So our resident education went on to the webinar model, which I wasn't quite happy with by that time. The reason because that it was still more of a monologue, and because you were not there in person, there were a lot of distractions, and the learning was very passive. Typically, the lectures are a monologue and there is a passive learning, but webinar to me seemed even more passive learning than what the classrooms were. And while they probably had their own role, and that is something that we should discuss today as well, my intention was to bring something which is slightly more interactive. where people can participate, share their thoughts, and discuss amongst in terms of how we should take our education forward. So I started with my residents where I created this, it's still a webinar platform, where my idea was that when people go for an evening walk, they can simply just put on their headphones on a phone and they can walk, they can do whatever they do in the evening, have a evening tea or whatnot, while also participate freely in an academic discussion for an hour, be it related to a illness or a disease or a case or whatnot. So that was the whole idea. For the first 8 sessions, we ourselves did not know how to format it. So we kind of walked around and tried to analyze what will be the most workable model. And since I started recording it, even evening walk was not feasible to me because outside there was a lot of ambient noise, which was catching up with the recording. So eventually I took a seat where now I started doing it on laptop, but I still suggested my attendees that you can still go for an evening walk, do your evening activities while also participate. So like, driving in your car, using your dead time to do whatnot. So we started recording our sessions from session 9 onwards. And those are the sessions that we have got. And if you go back and listen to those archives, you will see we were quite naive at that time. There was a lot of noise in the background, and the format was not very clean as to speak. And we were still trying to figure out what would be the best way to make it happen. After 50, 52 sessions, now we are kind of more or less set in terms of how we think the huddle should run, which is what we have been doing over the past few months, where we take up a clinical case or a very precise topic, and then we ask our attendees to share their thought process. And for most part, we do talk science, we do talk a little bit practical aspects, we do talk tips and tricks of how to make it work around. So the sessions that we have done from 9 onwards, and most of them are available on YouTube and podcast. I'm just going to name them so that we all are aware of what all we have discussed. We discussed the role of hypertriglyceridemia and its predictive value in preventing or predicting atherosclerotic coronary artery disease. We had one session talking about how should we time antihypertensive drugs, whether we should take it in the morning or in the evening. Is there a particular drug that should be taken in the morning or evening? We spoke in one session about hyperuricemia, how increased uric acid has got interplay with the coronary artery disease, heart failure, and other interventions. We had a long discussion, which was the longest session that we had, on plant-based cooking oil and cardiovascular health, where we had a surgeon and a dietitian discuss with us about which kind of oil we should be using and how to best utilize this fat intake so that it helps us and at the same time reduces our risk of atherosclerotic heart disease. We invited endocrinologists and discussed about how to place oral hypoglycemic agents beyond metformin, because most of us we become very comfortable with metformin, but anything outside of metformin, then it becomes a little bit of guesswork. We invited Mr. Dinesh Thakur. He is a whistleblower in the Ranbaxy case from year 2008 to 2014, currently Florida based. We invited Dinesh Thakur and we invited cardiologist from Cleveland to discuss about drug quality, both in US and in India. So we had a two-part series. In first part, we discussed about drug quality in US, and the second part, we discussed about drug quality or API quality in India and how DGCI plays a role and whatnot. We had one session with Dr. B.K. Shastri talking about pulmonary hypertension. And while we wanted to do a second part series to that, that didn't happen because of logistics and unavailability and whatnot. We invited one of our SEBI investors, Dr. Vijay Pava, who happens to be an MBBS graduate from AIMS, and he took us through how to understand financial investments and whatnot, and how to make ourselves financially independent. We spoke about outpatient management of SARS-CoV infection that was in the first wave of COVID that we had. This we discussed in September 2020. We spoke about antiarrhythmic therapy for atrial fibrillation going beyond amiodarone. We discussed thrombotic disorders. We had a multi-panel at that time, including hematologists as well as lab medicine doctors, to discuss about how to do the testing and what should be the best way to diagnose thrombotic disorders. We discussed pericardium cardiomyopathy, and for that we had Dr. Krishnam Raju and Dr. Manjula Anagani, who is a renowned gynecologist. We had to discuss about pericardium cardiomyopathy prevention and treatment. We discussed hypertrophic cardiomyopathy. For infective endocarditis, we had two sessions. One, we were discussing empiric therapy for diagnosed infective endocarditis, and one we had where we were discussing about antibiotic prophylaxis for infective endocarditis. We had one dedicated session for obstructive sleep apnea and one for orthostatic hypotension where we were discussing management challenges. In one of the sessions, we invited our chartered accountant to discuss about income tax basics, how we should be filing our taxes and what should be the best way to save money to the very best that we can from the doctor's viewpoint. Then in one of the sessions, we discussed drug-induced coagulopathy, how to manage patients who have got deranged INR in terms of how to advise them. And then we had one session for ischemic cardiomyopathy, one session for cardiac rehabilitation, where we had a panel of physiotherapists, behavioral psychologists, and all those who helped us with defining how cardiac rehab plays a role after MI. We had a session on stroke prevention in atrial fibrillation, where we discussed about the role of left atrial appendage closure. It is pertinent because in the recent ACC, we had this data LAOS 3 trial where they said that surgical left atrial appendage occlusion is associated with improved stroke outcome later on. So I think these are very relevant topics. In one of the sessions, we discussed adult vaccination. What are the practice patterns? What are the challenges? And these vaccinations we are talking about not related to COVID, but related with influenza and tetanus and pneumovax and whatnot. We discussed about high altitude travel with heart disease, iliofemoral DVT, how we should treat, particularly mechanical as well as pharmacological. We discussed stable CAD, the role of angioplasty versus medical management. In one of the sessions, we had discussed long distance travel, risk and advice, particularly those patients who are planning their travel to US and UK, how we should advise them, what medicines to keep in reserve, and how they should do certain things to prevent their DVT, pulmonary embolism risk and whatnot. We discussed about resistant hypertension, how to treat. We discussed post-bypass long-term follow-up, what kind of treatment regimen they should be. In one of the sessions, we discussed about mixopathy. Mixopathy was a term which was quoted a few months ago, where IMA was on a strike against the government order that certain Ayurvedic practitioners, they should be able to they should be allowed to do modern surgery. So there was this term that was coined as mixopathy, and IMA was not quite happy with that. So I seek opinion from our attendees regarding that. We discussed pulmonary embolism, smoking cessation, Takayasu arthritis, ASCVD risk assessment in elderly, how to add value to an OPD visit, where we were talking about how we should emphasize value addition in whatever we do. We discussed about LV thrombus, how to anticoagulate those. Thanatophobia, which essentially is fear of dying, because that was a very relevant thing we were seeing in our OPDs in this COVID scenario. We discussed Ramadan fasting, what advice we should give to our patients who have diabetes and heart disease and whatnot. Paroxysmal atrial fibrillation, alternatives to amiodarone. This was the second session that we did. The first one we did was last year. Hypertensive urgency in limited resource, where a patient calls you and says, my blood pressure is 200, what to do? And the last two sessions, we discussed about managing volume overload with regards to pharmacological diuresis versus ultrafiltration. In the very last session, we had a very pertinent topic in terms of role of anticoagulation in COVID-19 patient, because now, as you know, any patient who has got even a touch of D-dimer positivity, they are being put on anticoagulation. And sometimes even without D-dimer elevation, they are put on anticoagulation. So this is a list of all the topics that we have discussed. And my intention is that as we go along, maybe in the next few months, I should be confident enough to say that if there is a clinical scenario which is common in your practice, we must have discussed it in our huddle session. So the idea here is that over the time, we will have a repository of all the case scenarios that we have discussed, where anybody can go back and use it as a reference in terms of how people are discussing and making clinical decisions um, that take science into account and other pragmatic things into account. So that is my overall idea. For today, we are trying to go back to our basics, how education should be, how learning should be. How are we going to unlearn ourselves with the things that over the time we have learned doesn't work, and relearn so that we come out more knowledgeable and come out as a better clinicians. Doctors' work is called practice for a reason, because we continue to practice. We practice till the very day of our so-called professional work. So with that, a few key questions that I put in over here is mode of delivery. From talks to webinars, do we have a sweet spot? What should be the best way, how we should educate ourselves? And then the whole question of evidence-based learning versus experience-based learning versus value-based learning versus, is there a sweet spot in the middle? And then somewhere I read the modern literacy is unlearning and relearning rather than relearning new things, because at some point we have to unlearn, or we have to shed off the bad learning that we have got over the period of time, which weren't bad at the time when we learned. It is just that over the time we have realized that this probably is not the correct interpretation. So that was my 18 minutes monologue. I'll open it to discussion. You are welcome to unmute yourself, and I would request if you can open up your camera as well. I'm going to take a snapshot, and then you can you please feel free to keep your camera on for rest of the session. So because it is a education related topic, I can't find a better person than Somaraju sir to walk us through his journey of how education was at the time, and how do you think the modern education is going to be, and where you think sessions like this weekly huddle has a role. Dr. Somaraji, if you could take a few minutes and walk us through, and I request my attendees to turn on their camera so that I can take a snapshot of your presence. Somaraju sir, if you could just
Anup, good evening to all of you. And there is some trouble with my camera. It's not working. I'm not able to put it on. But on education, I want to listen to most of you. Then I'll add up whenever the issue comes up. Please carry on.
Thank you, sir. We'll stick to the format. Then we'll get to you towards the very end. Praneeth, you want to take over, and then we will go one by one. Tell me, what do you think?
Yes, good evening, everyone. It is very nice to reach this milestone. It is definitely something which I cherish for the rest of my life, something which we started, myself and Anup, which we started in the lockdown discussing what do we do, how do we pass our time. That is where the idea came. So the entire discussion or the focus was that the education process should be free, where it should not be effort taking. People should not be struggling to make presentation. They should not be reading. People are enough educated, and the mere sharing of knowledge itself is quite valuable, which is where the discussion came in. And as Anup was saying, that the resident level discussion which we thought of starting, the first thing which we said that no, residents are not supposed to do any homework. We will be doing all the homework, and they will be mere participants and uh, understanding or listening to us or sharing our thought process, what the clinical discussion which we do daily sitting in our cath lab console room discussing on cases, the same thing we will do it on the platform. That is where it all started. Now that we came at this milestone, the web-based discussions is what I think is really valid at this point of time. Most of the conferences which were kind of a dream for most of them, the ACC or European cardiology meetings or whatever. Right now, what do you call it? We call it as a blessing in disguise, where these things which were not possible to attend, major conferences, with the current web-based interactions, we are able to interact with people. We are able to know right now, and this, I think, is definitely something which is important, where distances are now shortened, and we are able to address a lot of people at the same time. So I would see this as a welcome sign in terms of education. And most important thing, these interactive sessions are something where the knowledge or the thought process is being shared without any restriction, is always a welcome. And when two intellectuals or two intelligent people sit and chat for some time, no matter even whatever it is definitely worth more value. So I see this as a valuable session, and I think most of many of sessions like this should be a part of our education system. Thank you, Anup.
Thank you, Praneeth. Srinivas sir, I'm going to ask you one question. In the, in cardiology, we talk about cardiology is so much science, evidence-based and whatnot. And we have got what Praneeth is saying. We have got so many CMEs which are accessible to us, which earlier we had to actually make an attempt to go and attend those. We all know this is not a secret. We all know almost 100% of CMEs, if not 100%, almost 100% of them are sponsored and have an agenda somewhere. We all know that if there is a talk in a conference, that talk is because there is a direct business transaction between the speaker and somewhere who is talking or whatnot. What do you think? Just mere fact that CMEs are accessible to us, do you think they still carry the badge of being the best platform for us to continue our education? Srinivas sir, what do you think? Am I being too critical of these things?
Anup, no, though they are sponsored, it's not like whatever is presented in CMEs. There are certainly, based on facts, like all the newer interventions which are helpful now. We learn a lot from the CMEs now.
Srinivas sir, your voice is breaking now. We heard you earlier, now your voice is breaking. No, we are not able to hear you. Srinivas sir, we are not able to hear you. Okay, I'm going to come back to you, sir. There is some issue with your audio. Let me ask Dr. Ravinder Reddy, sir. Dr. Ravinder Reddy is a senior surgeon with us at Care Hospital. Sir, you are in some CME speaker model every week, pretty much. What do you think? Am I being too critical? What is the best way you think we will learn rather than organically learn? What do you think in the current era? How learning should be designed for us? Ravinder sir, we can't hear you as well. Is there a problem with my mic? I don't know.
No. Good evening. You can hear me now?
Yeah.
I mean, I
yes,
forgot to unmute myself. Thanks a lot. Thanks a lot, Anu, for giving me the opportunity. And again, it's an absolute pleasure and an honor to be talking, especially in front of all the stalwarts and the leading cardiologists, including Dr. Somaraj Garu. Right. Now, yeah, in a way, almost every week I am involved in a talk or the other. And majority of them are actually industry sponsored, with very few sponsored by an education society. In the last year, I think out of 12 lectures, only 4 of them are given on the education society platform. The remaining have been sponsored. Having said that, I do not know of any Anoops and Dr. Praneeths who actually conduct such conferences without any bias, right? Other than these education societies. So the need of the hour is actually to be it sponsored by the industry, be it sponsored by one fantastic individual such as Anup or Praneeth, or including all the societies like cardiology society or surgical society or nutrition societies, which are probably once or twice a year, uh, not very much. So it is in these situations where we actually train our youngsters. You have very rightly pointed out in your initial monologue to say that we have to unlearn many things. I would go a step further, and we can use these platforms to actually teach them the correct way, teach them the basics. Even though most of my lectures are sponsored, I tell them very clearly, I'm not going to talk about your products or anything like that, and I'm going to stick to only basic sciences and evidence-based medicine. I'll give an example. Recently, for Bangladeshis, they asked me to talk about SMOF Kabivan. It's a kind of parental nutrition. I actually talk more about SMOF, saying that why it should not be given in critical illness, right? So it defeated their purpose, but then I thought I'm giving the appropriate message. So yes, in a way, if people want to actually indulge their sponsors, they can do so. But most of us who actually take part in that, we generally stick to the evidence-based guidance because that is how we build our credibility. Tomorrow, if I go on giving the same message of the industry, then it is my reputation is at stake, right? So basically, I mean, that is the reason why we welcome any of these platforms wherein we can teach the youngsters. And the most important thing is catch them young. Catch them young. We need to catch our postgraduate students because one of the limitations in India across all fields is we stop teaching them the basic sciences and safe medical practices. I think I've spoken enough, and thanks again, Anup, for the opportunity.
Thank you, sir. Let me ask Dr. Rajender. Dr. Rajender, I think you and me both are in that phase where I think we are still learning. I think we haven't plateaued. We have seniors with us in their late 40s or mid 40s, early 50s, who are plateaued in their what do you call professional work as to speak. They're working in a cruise control mode. For people like us, we are still actively learning. We are still trying to find a place for us. How do you or what kind of education model you consume in your daily activity to keep yourself up to date with either skill or bedside knowledge, decision making, research trial, whatnot? Give us some idea. How do you keep yourself updated?
Good evening, sir. Good evening, everybody. So yeah, once I started my training in Bitcare in 2015. From 2015 to 2018, it was like going through bedsides and studying for the didactic and all other things like the theory and practice and bedside. After I done my residency, once you come into the practice, general practice, so it's more into intervention. But yeah, the COVID era has given us a new insight that how to learn from a distance. Like I watch many videos which help me improve my skills, especially the intervention skills, especially the radial intervention skills. I watch many videos of different authors which showed multiple newer techniques, and especially in my devices also there were new methods, steering methods by renowned cardiologists like Seth Worley, and they really helped me graduate to a next level. It was like a step-by-step approach and say device like CRTDs, which earlier it took a lot of time to hook to put in an LV lead. So I started with at least 3 hours. So once I went through these videos that were quite simple, step-wise, elegantly paced. So this COVID era, the new technology and these videos really helped me in my daily practice. So it's a boon. No doubt, COVID has played a havoc with our day-to-day life, but it has helped in long-distance education and technology playing a vital role, pivotal role. Thank you so much.
Perfect, Dr. Rajender. Let me get to Shankar, sir. Sir, I would like you to spend some time with us explaining how education model was, and I don't want to say back in the day, but let's say 15, 20 years ago, within doctors. I'm less, I think we are less talking about MBBS education. We are more talking about education amongst doctors. How we were updating ourselves 15, 20 years ago and how we are consuming knowledge now. And where do you think places like these like huddle or whatnot, where more of an informal interaction, like how do you fit these things? Because truth being told, the bedside education, COVID just hit a nail on it. It's very difficult for me to see how these things are going to evolve now. A, we will hopefully have a day when we won't have a COVID kind of situation. B, we would have enough of bandwidth where hopefully we will go back to the bedside teaching or whatnot. Even for consultants, I'm not talking about just the MBBS students and residents. We also need to learn ourselves over the period of time. If you could reflect upon what was happening 15, 20 years ago, what is happening now, and what do you think how education is going to take over in the next few years? Shankar sir.
Good evening to all. At the outset, I feel privileged to congratulate Dr. Anup Agarwal and Dr. Praneeth Polamuri on the eve of first successful anniversary of our weekly huddle. In fact, I joined in the middle of the huddle from 30th episode, I think. I found very interesting. I appreciate the spirit, zeal, enthusiasm, commitment, love, and dedication in conducting uninterruptedly the educative sessions like this to impart knowledge and share our thoughts. My hearty greetings to them once again on this happy occasion. See, in my view, a doctor should always be a student till he dies. He should keep on learning. He should update and should be up to date. If a doctor considers himself not a student anymore, the doctor in him dies. He is no more a doctor. So these are the words of our senior teachers like Dr. Somaraju sir. So since I joined my education, I have been following the same. Even today also, I read a lot. And I keep myself updated. Otherwise, in this competitive world, we will be thrown back. So earlier, we had very good teachers and there were no corporates. And the doctor, even our teachers were very much dedicated. Now we are seeing other way around. By 10 or 11 o'clock, they finish up their rounds. This is literally I'm seeing because my son was there in the education, in the medical education. So I took a lot of care to teach his batch, to engage them in engage with the other seniors whenever they feel free. So by 10 or 11, they leave. So the students are left now without any teaching. There is no zeal or enthusiasm amongst the teachers. See, I quote Dr. Somaraju sir here, the iconic figure and the doyen in the field of medical science. So he is our mentor, guide, philosopher, and role model to all of us. So I still remember his words. You teach. If you teach, I forget. If you teach me, I forget. If you show me, at least I remember. If you involve me, I learn permanently, perfectly. These are the principles followed by Dr. Somaraju like teachers, Dr. Dayasagar Rao, Dr. Koppachi Krishnamurthy, Dr. N.R. Rao from Kurnool, Dr. C. Mallikarjun Rao from Kakinada, Dr. Chitti Pantulu from Andhra Medical College, Dr. S.R. Rao from Usmania Medical College. So likewise, we had very good teachers. We had very good foundation in our undergraduate studies. See, I'm surprised to tell now, recently on the last Sunday, I attended a master class conducted by our Cardiological Society of India National, organized by Dr. Ketan Mehta and Santanu Guha. One DM student presented a case. He was very much biased in the beginning only in presenting the case. He knows the diagnosis. He was presenting the in that manner only to arrive at his own diagnosis. So Dr. Das Sagar sir and Dr. Narayan Swami, they were examiners in that. It was a virtual webinar, a master class. So even he could not answer certain things what we learned in our undergraduate studies. So where are we going? See, we are all tech-mediated individuals. So we don't know how to palpate. He never mentioned that parasternal heave in that case. He was not able to even chest X-ray actually in one of the CSA conferences, because I am a primary care physician. I am not a cardiologist. So because of necessity is the mother of invention and the father of progress. Here I was the first physician settled in 1983. There were no physicians. I was the first physician. There were no, as a cardiologist means not to be seen in only Hyderabad. So in that situation, I was compelled to learn many things. ECG. We had a very good session with Dr. Somaraju sir in Nizam Institute. Why I am telling all these things? Because the education was different in our undergraduate studies or postgraduate studies. Because after the advent of the corporate sector and the pharma companies have taken over. They at their whims and fancies, they are conducting to support their own products. So this is happening now. So Dr. Somaraju sir, since inception in the medical field, whether he was in Usmania, whether he was in Nizam Institute of Medical Sciences, Medicity, Shantabai Nursing Home, Care Hospital, and now even in AIG hospitals, he has been very much interested in teaching his students. So for all of us who are trained under him, we treat him as a god. Even the patients also, they feel with the same Vaidyo Narayano Hari. So this type of dedication, this type of commitment is lacking in the younger generation. So we were lucky enough to have only that time, even private medical colleges were also not there. Only two medical colleges, Gandhi Medical College, I was alumnus of the same, and Usmania Medical College. And later Kakatiya Medical College joined. So the teachers have no other go except teaching. And a very good model we have seen is a Nizam Institute, where the teaching faculty is not allowed to practice. Even if they are allowed to practice, only that is evening paying clinics only. So that gives a lot of time to read for them and teach teachers, and the commitment will be there, and there will be a lot of beneficial effects to the students. I personally feel that if whoever is interested in teaching, they should be highly paid, and they should not be allowed to practice in the evening. With these few words, at present times, we see even our patients, they have become masters in the Google University. The moment we say that third heart sound is present, he immediately will search in the Google. You Google it, the Google Mama tells the children, pregnancy, mitral incompetence, left ventricular failure, and all these things. He thinks that all these things he may be having. So he will make a fuss and mess in our clinic. So at the same time, we should keep pace with the present knowledge. The medicine is highly advancing. It is very difficult to keep pace with the newer developments in the medicine, because even if I want to go through one COVID trial, there are 5 lakh papers have been published in a national and international reputed journals. How to go through those 5 lakh articles? It's very difficult. So we have to go through the updates. You should go through the review articles. We should go through the guidelines. Then only we can do justice to our patients with evidence-based, experience-based, eminence-based, and expert-based. All these things are quite essential to practice in this era. We all should transform ourselves into digital doctors, because the other day, 10 years ago, I wrote one rosiglitazone. That time it was very rosy, but later it was banned. So the same prescription carried to United States, they ridiculed. See how this doctor has written this banned drug. So immediately they Google it, whatever we write, whether what are the side effects, what are the adverse effects, what are the contraindications, what are the indications. Immediately they question us. Now at this juncture, practicing with Googling masters, it's very difficult. And at the same time, we should transform ourselves into digital doctors, not unlike what we were facing in the past. Thank you, Dr. Anup, for giving me this opportunity to interact with you. All the one sentence. See, we have Dr. Somraju sir, and we should agree that as age passes, we may lose our memory. We gradually lose our memory. So one doctor, Dr. Rajshekhar, Professor Rajshekhar from Kumbakonam, Tamil Nadu, he formulated many acronyms. What we see in the Chadwa score and Highest blood score. Likewise, he formulated many mnemonics to memorize the subject. So I want to emphasize that Dr. Rajshekhar from Kumbakonam, Tamil Nadu, Professor Rajshekhar. And concluding remarks, really, I'm fortunate to have that real torch bearers, Dr. Anup Agarwal and Pranit Palamuri, to carry the mission. Dr. Somraju sir, I think he has not left, but he may be on the verge of leaving. We have got a ray of hope. Even the silver lining in the dark clouds, the torch bearers, we ultimately got Dr. Anup Agarwal and Dr. Pranit Palamuri to carry on this mission with the same zeal, enthusiasm, and to dissipate the knowledge amongst our medical fraternity. I wish them a grand success. Thank you, one and all.
Thank you, Shankar sir. That was really appreciative of you. What am I if I cannot put some fire in today's discussion? So I'm going to play a little bit of devil's advocate. So Dr. Ataullah, are you able to hear me? Looks like his network is a little bit off.
Yes, sir, I'm here.
You're able to hear me, right?
Yes, sir, I'm able to hear you.
Okay,
Sir.
okay. I have a question for you. And I'm going to keep Dr. Shankar mute here because I don't want him to respond to my question. So, few years ago, I heard Gulzar in one of the interviews. You know Gulzar? Gulzar,
Yes.
You know Gulzar, he's a very famous lyricist, right? Okay.
Yes, sir.
So at one time he said that I hear veteran lyricists in the Bollywood industry who complain about how bad lyrics are being written now and how well lyrics were written back in their day. And I tell them only one thing. That means you only took the fruits at that time and you did not sow any seed. So you did not do anything for the future. What you are seeing is the future. If you would have sowed good seeds back in the day when you were on the top, then you would probably have as good of lyrics right now as what you had back in the day. So you cannot complain. And if you think today's situation is bad, that is probably because at your time you didn't do anything good. So me, we are in that era where we are still learning. What do you think in terms of today's education from your viewpoint? Do you think that the criticism that today's education is not at par as what it was 15, 20 years ago? And if you think it is truly not at par, how do you think it can be made better? And Dr. Praveen, I'll come to you after Dr. Ataullah. Dr. Ataullah.
So sir, one thing what I noticed was I was reading the 20th edition of Harrison, and we have a 18th edition of Harrison in our room, in our duty room. So I don't know, I somehow always go back to the 18th edition Harrison because I feel it is more easier to read and understand. And I don't know, somehow now the education is all monotonous and everything. So one sort of groundbreaking thing for me was when I attended the cardiology, when I started the cardiology peripherals, where thanks to Praneeth sir, I got to know there are other sources also where I can learn from. I didn't know about this podcast until recently when I joined the cardiology peripherals. So there are other sites you can go to learn. We have video lectures and whatnot. So that was very groundbreaking thing for me. We have so many resources that our seniors just don't know, and they don't tell us about. So I think that somewhere there's a gap in the person who is learning right now and the person who are what we think are learned, who are seniors to us. They somehow even they have a deficiency where they don't know what is happening around them. So I think even like to follow proper teachers is a very big plays a very important part. And don't know, somehow I think that has to be also looked after a little bit.
Perfect. Thank you so much. Thank you so much for sharing your thought. Dr. Praveen, what is your thought on this? And then I have one more question for you. Dr. Shankar said patients Google their symptoms and their concerns and they come to us. It makes our life difficult. Well, guess what? Don't you think doctors also Google how to educate themselves? So if doctors can Google, and if we think we are smart enough to pick up the correct information that we want, how are we judging our patients? Don't we think our patients are also smart enough to pick up the correct information? So why is it that we are allowed to Google, but our patients are not? That is one. And second, about the education thing, in terms of how do you think a modern doctor in the current era, now we are talking kind of COVID and webinar and whatnot. In the current era, what do you think the education model is going to be? And why do you think Google is frowned upon by the patient, but is readily accepted by doctors? Okay, unmute yourself first.
Good evening, everyone. First, I would congratulate you, sir, on the first year edition of the Weekly Huddle. Coming to the topics regarding the education, I would say that the present education system, whatever is going, is not up to the mark. when the usual mindset that will be going in the present situation, which I would see being from the 2001, where which I have joined the MBBS, is what you call during the MBBS, they would say that it is not up to your mark. That is, it should not be known at your level. That is, you will be knowing only after you go to the PG. And in the PG, they would say that nothing would be taught to you in full. You should be reading by yourself. That is fine, because you have to develop your own capabilities. At the same time, they would say that you have come to PG, you do not know this also. And when the situation is the same in PG like that, and if you come to super specialty DMPG, the interaction would be very less, and they would say that without knowing this, you have come. That can be taken on a lighter note, but the other thing would be is the age of the PG will be increasing, and there will be also some amount of what you call he will be restricted to ask, if we ask this question, what would the professor feel? And at the same time, the other thing would be is he would be in a batch of the already his colleagues. He would be feeling very inferior, or what you call, if I ask what would be there, this would be there. I am not saying it would be for 100%, but at any point of time, I have felt, and others might have also felt. They might not be telling that, but at one point of time, we'll feel that we'll be feeling what you call just like the patient feeling in what you call very restricted to ask some question to the doctor, where they say that patient should not hide anything from their doctor. At the same time, during our education, we feel sometime when others are performing or anything, we feel somewhat inferior, and we may see the opportunities to go ask, and the teachers secretly rather than in our audience. That is one thing. And the other thing I would say is regarding the education, the whatever the case discussions that are going, that are based upon the final diagnosis. The whatever the student is presenting, it's already known, and based upon that, the discussion will be going down spiral rather than that of the up spiral. That is, if patient is having heart failure, the symptoms of approach to a patient with the edema will not be, the discussion will be not going, it will be in the down spiral. That is based upon the, we'll be coming to a diagnosis, so that we have to reach up the diagnosis. The discussion will be going on like that, which leads to what you call narrow-minded approach. That should not be done. Now, here seeing in our scenarios, which we are doing in the weekly huddle, it's very useful. Why? Because there is an unbiased approach, and we are not supporting any of the other pharma companies or anything, which will be usually happening in the all the webinars that are being approachable by the all the across the net. Say, for example, if one pharma company is supporting the fixed dose combination, and which usually which we read in the textbook say that fixed dose combination is not beneficial because of the contrary effects of individual drugs. But when we are doing that webinar, we are forced to tell that the particular fixed dose combination will be working well. Sometimes we can tell that to the pharma people that we will not be able to promote your product, but in the indirect way that we will say that this fixed dose combination we will be highlighting. Obviously, everyone will be knowing that it is their pharma company and all that, because all the pamphlets will be kept and all that. No webinar will be conducted where there will be unbiased promotion of the particular product. So the other thing is, sir, whenever we are doing, hello.
Yes, Praveen. Yes, we can hear you. Please go ahead.
Sir, the other thing I would think that is required in our present education is that we should be given a topic or anything to the youngsters and do the teaching on the board. That was the teaching that our teachers have learned. That is what you call, you will be given a topic, you should be teaching on the board, and you should be you should recollect what you have read and able to do it. What is happening now is the present technology where we will be using all the PPT that is ready to serve. If you have given one topic, you can just Google it, you can download it, you can make the necessary changes and do it. What will be is, it is just like a ready to serve, and you will not be deeply involved in the subject. And coming to the questions that what you call, the patients will be Googling it. Most of the patients, they Google, why? Because it is easy to access and they have particular questions to ask to the doctor. But most of the patients will come to show that they know regarding their diagnosis previously, and they just come to test the doctor whether they are giving good treatment or not. In one way it is good, but in the other way it what you call thins out the trust between the doctor and patient. And regarding the doctor Googling the what you call regarding a particular diagnosis, again I would say in the same scenarios, same way.
Perfect. Thank you so much, Praveen. I think that it is quite relevant in the current discussion that we are having to hear opinion from across the board. Dr. Ataullah, I'm going to come back to you for 30 seconds. Your opinion for 30 seconds. You heard about what we are doing. You heard a few sessions and whatnot. I want to ask you one question. And you spoke to, you heard Praveen talk about the model of education. You heard Dr. Shankar about non-availability of good education platform or non-judgmental education platform or whatever. The hospital where I work has got 12 DNB residents. And Huddle typically has 1 to 2 attendees at the max at any given time. Why do you think that is the case? Dr. Ataullah.
I think most of the people don't know, sir. That is one thing, and the other thing might be some of the residents are in night duties also. So that timing, I think, to adjust is a little bit difficult. And I think the major thing is most of the people don't know. Because I didn't know until I came to my peripherals. So I think I have posted it in. I think Divya ma'am also has posted it in our group. I think more DNBs ought to know. And I think there one more thing is there ki they might be restricted ki this is only cardiology. The huddle might be only cardiology. So I got to know ki it is even more related to medicine than just strictly cardiology. So that might be the reason, sir.
Perfect. Thank you so much. The last but not the least, Dr. Somaraju, if you could please share your thoughts. You heard all of us discuss about this. While it is 7:59, please take your time and walk us through what do you think the model of education is, and what do you think we should be focusing on? Dr. Somaraju.
Good evening to all of you, and my video is not working, and I'll just share some thoughts. Thank you very much for arranging such a very important issue. And while before I talk anything more and end it up, I think we should continue this next session also, because the whole issue cannot be, it's too important and too large an issue. And even your next hurdle should be continuing on what we are talking about today, because some more things have to be done. And I'll tell you about, say, some of you mentioned that I taught them and then they were influenced by all that. But I must also tell you, as a teacher, I didn't tell them too many facts. I always insisted on teaching them and telling them attitudes. The behavioral requirements to try to learn. The methods of learning to learn, the methods of learning to think, and habits of a lifetime, which will make you continue to learn and continue to teach. And these are the things that I always concentrated. And I didn't teach them too many facts. The facts are available everywhere, particularly today. And having said that, I'll just tell you the two important examples I'll give you. Medical education is in a bad shape, particularly in this country and to some extent, some aspects, other parts of the world. Then I'll give you two examples about what's happening around. Recently, we had 4 students of MD medicine posted from, say, some medical college in Karimnagar, who were posted with us. I am at AG hospital now. And then they were posted with us for training in cardiology. They come for 1 to 3 months. Then, just like any other batch who came to us, we teach them, and more than one of us got involved in it. And we also told them that you have to do 1 night duty a week, and you will learn how to manage emergencies and all that. Then they came back second or third day and said, "Sorry, sir, we cannot do night duties." The reason they cited was that they got tired if they do night duties. And then we told them it is zero tolerance with us if somebody cannot do night duties. It is a 24-hour job for us. And whatever happens around, we don't care. We have a different system and we have a different model. Certain things are zero tolerance for us. If you can't do night duties with us, we can't be working together or learn from each other. So then they said, if night duty is compulsory here, we want to go away to some other hospital and get taught. So they left. And then that is the status of attitude problem in medicine now. I think Dr. Shankar mentioned some of this. And second thing, taking examples from this tragic pandemic we are going through, this pandemic is say, the worst that ever happened to us in our own lifetimes and maybe lifetimes of generations together. Having said that, this pandemic also gave us an opportunity for medicine to regain its last trust in public. And when I say this, all over the world, medicine was no longer voted as a very trustable, say, walk of life. So in other words, the last trust of medicine, we had an opportunity to regain it back during this COVID pandemic, dealing with patients, dealing with their families and whatnot. Then, and I must say, we didn't succeed in it to try to regain that trust. The private greed of our private hospitals and enormous exploitation of patients in all aspects in that private greed, and secondly, public apathy of government systems of healthcare. Both systems lost this greatest opportunity that COVID gave us to get back that, say, trust of public. And secondly, now, this COVID also taught us that the healthcare systems we are talking about have to change. Medical education has to change. It has to move away just from doctor model alone. And healthcare delivery system is more than doctoring now, or even nursing. It is the whole healthcare system delivery. All the people who are involved in dealing with the patient from the time of admission to discharge, from the time after discharge, follow-up, and treatment of wellness, illness, and both prevention. It requires some, suppose in a hospital, beyond doctors and nurses, we have, say, nutritionists, we have technicians, we have, say, the unsung heroes of medicine came out in this pandemic, namely beyond doctoring, the nurses, it's the technicians, it is say housekeeping, which is the riskiest job to do in this pandemic. Now they are as important and are even more important than many of us. And then whole healthcare system requires now to be educated together. When you say this huddle, I want to suggest the knowledge management in healthcare organizations is not doctoring alone. It is all of them. I request you in your next huddle, involve all of them. I wanted nurses to follow, to attend your sessions. I wanted the rest of the systems, including administrators. Then, as I said, throughout my career, I tried to teach attitudes. I tried to teach the methods of learning. I tried to teach methods of thinking, learning to think. And while I say this, moving forward, we have to involve whole healthcare system in our methods of education and knowledge management inside healthcare organizations. Then how we do it, how best it is done, I think because of lack of time, I won't insist upon it, going on talking about it beyond a point, except telling you the clinical round is the best opportunity to teach your junior. But now, with the advances in medicine, with the cost of hospitalization, etc., hardly any patient stays in the hospital more than 2 or 3 days before this COVID. COVID is different. This will pass on. Something else will happen, but this will pass on. But it is very important that we learn, we make our education continue to be into our outpatient system. Then each one of us seniors should be shadowed by your students, your junior consultants, as part and parcel of the education system. When they watch you performing both inpatient as well as outpatient, how you talk to the patient, what you do, what are the workup a patient and present to you, that should be happening not only in inpatient but also outpatient. An average DNB student in the inpatient hardly learns anything because by the time he saw the patient, next day the patient is discharged. And then the follow-up, the outpatient education is part and parcel of education. But I leave it here. I think it's an extremely important area. Anup, I must congratulate you for taking this up. And I have a lot of more things to say, but I think we should continue this next time. Thank you. I'll leave it here. Unless any one of you have any questions.
Sir, what I intend to do is I take cue from your thoughts, and what I will do is let us continue where we leave right now today. Let us continue next Wednesday right from here, and we'll have you finish
I
your
just
thought.
want to say one thing more.
Yes, sir.
While we say the medicine, when we were initially when we were students, The questions used to be asked whether it is science or art. Now it is neither of them, it is business. It's money. Now, how to, I am not saying that money is not important. Nobody should say that. But money is part and parcel of everything we do. But while we say this, it is important that as professionals, we can overcome this problem and make a balanced method of systems of care where, say, certain professions, two components in it. Number one, the public and the government should know that certain professions have to be treated differently by the society and public and government in general. Medicine is foremost in them. Before medicine, I must say education and teachers. Next, medicine. Next, say, judicial system. And our protectors, namely police and soldiers. And these professions have to be dealt with differently. They have to be paid more than anyone else. They should not be thinking about money. And they should be paid and dealt with them in such a way that they give their best. And public policies have to be changed for it. Having said that, in medicine, what we can do, we have the power, we have the opportunity. What I suggest, next time I'll tell you more, that all of us should come together irrespective of wherever you work, across the healthcare system, not only doctors and nurses alone, all others who are involved in it, and form multidisciplinary, multi-system, specialty teams across, say, start with Hyderabad, next both the states, and then we start insisting upon forms of conductance in such a way we take the authority of making hospitals run the way we want them to run. And then authority in medicine cannot be given, it has to be taken. When we come together, irrespective of wherever we work, it doesn't really matter you have to be in one hospital. You have to form a system or a groups in such a way we all work together to take this authority into our hands and make medicine in the way it should be practiced. And I'll talk about this more, why we can still form teams across Hyderabad, across both states, across India, and medicine has no borders across the world. And we'll talk about it more later. Thank you.
Perfect, sir. I request you to continue your thought next time, next Wednesday when we continue the same discussion, and then we will continue hopefully with the thoughts that you leave with us right now, and we will bank upon it. We will work more upon it. Hopefully, we'll have more things to share at that time. For the next 1 or 2 more minutes, I'll just take thoughts from a few more people here. We have Salma in the audience. Salma is our heart failure nurse who had been a regular attendee of the huddle. Salma, if you can hear me, could you please unmute yourself and just share your thoughts about what have you gained attending the huddle session, which is primarily designed for doctors. I wouldn't say cardiologists, but for doctors as a general. Salma, if you could just unmute yourself, 30 seconds, if you could just share your thought. I'm not sure if you're able to hear me. Yes, Salma, please go ahead.
Yes, sir. First of all, a very good evening to everyone.
Salma, we heard good evening. After that, we can't hear you. Okay. Salma, I think we have got some network issue. Let us do this. We will save this question for next session. Next session, we are going to continue on the same topic. We are going to continue on new age learning. And Salma, we will start with you next time. Sir. We will ask you this question.
Anup sir.
Yes. Yeah. Hi, Dr. Gopi Krishna. Please go ahead.
Sir, good evening. Actually, sir, I should say a big thank to you, because really you started a one platform for us, the doctors like us who are practicing in the periphery. I'm here in Nizamabad. I'm running 2 hospitals, and one hospital I'm running in Armour, where I want to reach the outreach people where primary angioplasty and cardiac care is important. Till now, it's not available in these places, and I'm doing that work now. Can you hear, sir, or any problem with my audio?
You are absolutely
Hello?
audible, Dr. Gopikrishnan. You are absolutely audible. Please go ahead. Yeah.
Because I'm working in a poor network area, so
You are absolutely.
the one thing I want to, thank you for asking our opinions regarding these meetings and platform. So how to improve our education system and everything. Actually, I want to give one advice, sir, which is really useful for everybody, because I'm a student. Actually, I want to practice with the general medicine only. I want to practice the general medicine itself. But one person in my life, who inspired me a lot to enter into cardiology, I don't know, it's surprise to the doctor also. That great personality is none other than Dr. Somraju sir. He is my role model and my teacher. I think so many doctors like me are inspired by sir. I think sir probably don't know about the existence of doctors like me. So many times I want to meet sir personally, but somehow I could not meet him. But I think sir now hearing my words, because I'll tell you one example of perfect teacher, how the teacher should be. Sir was working in a care hospital, Banjara Hills, and I used to attend the classes of Somraj sir regularly. And even I used to attend all classes which are conducted in a care hospital after my general medicine, after finishing my general medicine MD degree. So routinely I used to go and attend the classes, but so many times I used to feel like whether I get opportunity to work with the Somraj sir or not. One fine day, I gone for a class. The topic is that mitral regurgitation, about mitral regurgitation. Nobody else is there in the classroom. Almost all care students were absent because of, I inquired them, I called them. So somebody is telling that they're in the cath lab, one bad case is in a ER, and somebody posted in a periphery. So they have their own problems. I was just alone sitting in the room, and I was fearing Somraj sir will come, how he reacts, and I don't know what happens. Then, and I'm outsider by that time. I just used to attend the classes without knowing anybody. So I was in a fear. Then suddenly sir entered into my room, his room actually, where the class used to be taken, in that room only. So suddenly sir entered. Just he asked me what is the topic today. Then I said, sir, MR, but nobody is there. He did not listen even what I am saying. Just he started telling the MR class about the mitral regurgitation. I still remember that day. And see, for such type of personality, great doctor and great teacher, and for everything, for him is each minute is important. And I'm not belongs to even care hospital. I'm not his student. It's nothing to do with me, and he will not get anything, even a single benefit out of the telling this class to me. And when nobody is there,
that Gopikrishna, thank you very much. But can I add something here? Can I, Anup, with your permission, I'll interrupt him and just say one thing.
Please go ahead.
I used to tell my students and my colleagues also later that when how many students you need to take a class. People say 5, 10, 20, 30, 50, whatever not. Then I say, I followed something different. Even when one student is there, you should start the class in time. Don't wait for everybody to come. You may repeat for others who came late. Because whoever comes in time, we should not make them suffer because they came in time. And secondly, I even used to tell them, even if there's a half student, you must start the class. Half student by definition is, there's one student, but he is sleeping.
Sir, we have heard that thought of yours very loud and clear multiple times, and I think that is something we definitely will do, at least in the huddle session going forward. There is definitely, that is one principle we are going to follow.
And now I should thank Anup sir. After so many days, so many years, the person like you in the form of Anup sir, he has come forward and started some academic section and sessions, and even for us who are sitting in the Nizamabad or somewhere far away places, still able to update our knowledge and attend the classes. Even sometimes I'm trying to attend, but here we have to see all management issues also rather than a doctor to management issues. So I'm facing some problems with that, but still I'm trying to attend the classes, but really useful sessions, sir, for all of us. Should thank you. And after Somraj sir, now I'm seeing you, and I think you are the same person with the same interest towards teaching and encouraging the students for their growth and growth of the society. And everybody like you people, definitely they're so much helpful to the society rather than just a single student. Thank you, sir. Thank you very much. You and Somraj sir. I think Somraj sir forgotten my face also because yeah. But I really remember all the things and incidents and his passion, everything. He inspired me a lot. Thank you, sir.
Thank you so much. Thank you so much, Dr. Gopikrishna. Last comments, Dr. Praveen and then Dr. Praneeth, and then hopefully we'll be done at least with today's session. We'll have to wind it up. Dr. Praveen, please go ahead.
Sir, one comment I want to make regarding the present, the education and whatever is there. The education whichever is there, the for the doctors or not, if it is easily reachable, sir, then it gets diluted. Now the number of seats are there for each medical college or anything. They are what you call more number of the seats rather than that of the material that is available. And wherever the material is available, there are no adequate resources to do the education. So that is what I want to say now. The number of people that we are able to get now, if we just after the PG, if we just write the exam, if you just pass it out, then it will be coming. So the essence of the purpose of the training would be lost. They are allotting the seats just because there is need of the so and so specialist, but they are not seeing whether there is adequate material to teach or not. So that I want to emphasize.
Thank you so much, Dr. Praveen. Dr. Praneeth, please go ahead, last comment, and then we will continue this session next week as well, as Dr. Somraju suggested. Praneeth.
Yeah, I would thank everyone who have attended and made our special day more special. Education is something, or teaching is something which is equally passionate to me and even Anup. So we started this session something just as a hobby, or we wanted to it, and there were many adjectives used by speakers. I don't know whether we live up to the expectations or not, but what I can ensure is teaching is something which both of us are passionate about it, and I hope we will continue many more sessions where not only me and many of them are getting benefited from it. Thank you.
Thank you, Praneeth. Thank you all of you for attending, and we will have the New Age Learning Part 2 next Wednesday. We'll start with Somaraju sir. I will have specific questions to him about today's session and then going forward. And then we'll come up with new topics to discuss next week as well. Thank you all for attending. Good night. And virtual, please have a virtual cake from me. And hopefully when the COVID recovers, then we will have a get together. I promise you that's a dinner on me. We will make it happen. Thank you so much. Thank you all of you. Good night.